All right, welcome everybody to today's vitamin D study hour. Hopefully, everybody now is clicking in to join us. I've got Dr. Scott Weiss on today. Welcome.
Thank you, Jen.
All right, let's share these slides here. All right, can you see my screen okay?
Yes, I can.
All
Looks
right.
good.
Like I said, welcome everyone to our vitamin D study hour. Today, I'm honored to have Dr. Scott Weiss here, and he's going to be reviewing some of his latest publications on not just vitamin D, lung function, and asthma, but also on vitamin D and its distribution throughout the body in the different tissues, how the different tissues use the different metabolites of vitamin D, and it's all very interesting information that really explains a lot about, especially vitamin D in pregnancy and the development of the fetus. So, like I mentioned, the two publications that we have been featuring as part of the homework, as well as what is going to be included in today's presentation, are prenatal vitamin D supplementation to prevent childhood asthma, 15-year results from the vitamin D antenatal asthma reduction trial. So the VDART study, and that paper was one of several published based on the data from that study. And the other paper is Vitamin D Beyond the Blood, Tissue Distribution of Vitamin D Metabolites After Supplementation, published last year. So, Dr. Weiss is a professor of medicine at the Harvard Medical School. He also has an extensive background in environmental health, in respiratory biology, pulmonary and critical care, as well as genetics. So, he is also the former scientific director of personalized medicine at Partners Healthcare System and a co-leader of the Systems Genetics and Genomics Unit at the Channing Division of Network Medicine at Brigham. So he's also led or co-led a 30 investigator, 110 person research group that was involved in examining the environmental exposures and genetic risk factors for the development of asthma and COPD, and has led multidisciplinary cooperative studies of asthma and COPD with an international experience. He has authored or co-authored over 600 papers and co-written and co-edited 4 books, including a comprehensive textbook on respiratory genetics. And he is the recipient of several honors and awards, including the American Thoracic Society Recognition Award for his scientific accomplishments. And he was also recently identified as part of the top 0.004% of biomedical researchers in terms of the scientific impact of their work. Congratulations, Dr. Weiss.
Thank you.
Just a few reminders before we begin. We had several questions submitted ahead of time. All other questions can be submitted to the Q&A section and will be addressed after Dr. Weiss's presentation. This will be recorded and it will be posted to our website and our YouTube at a later date. And as always, remember grassroots health as your go-to, because when you measure your vitamin D levels and other health markers through grassroots health, you're also contributing your data to the vitamin D action study. If anybody has questions about measuring their vitamin D levels or how to optimize, which I think is probably even more important, you can always contact us or myself directly, jen@grassrootshealth.org. And before we begin, I do want to mention we're taking a short break with our vitamin D study hours for the rest of this month to focus on a few other projects. But we will be starting back up on March 4th with Dr. John White, who will be talking about kind of a similar topic, and we might refer to him a little bit later on. But he'll be covering his research on how vitamin D status affects the immune system. Followed by Dr. Mace McCoy, and she will be covering vitamin D in women's health on April 1st. And then April 15th, we will have Dr. Leigh Frame discussing her research on vitamin D exercise and outdoor activities. So Once again, email us with your questions, feedback, stories. Donations are appreciated. We are incredibly appreciative of our sponsors and our partners. And with that, I am going to hand it over to Dr. Weiss. Let me stop sharing for you. There we go.
Okay, can everybody see my slides?
I can see them, yes.
Okay, good. All right, so what we're going to do is I'm going to talk about vitamin D research before and after the vitamin D antenatal asthma reduction trial, the VDART trial. Uh, um, Give you some background, the results of VDART, discuss the results and try to put them in context. Uh, um, Acknowledge the people that worked on the study, and then we're going to take a bunch of questions. So, in terms of background, the first thing I want you to know is that vitamin D has profound effects on the immune system. All of the immune cells of the body, T cells, dendritic cells, B cells, macrophages, all of these different immune cells have the capacity to locally produce the active form of vitamin D, the 125D or calcitriol. Vitamin D also acts as a switch for the immune system to turn on and off the immune system's inflammatory response, both for the innate immune system and the adaptive immune system. And the VDR binding sites and vitamin D itself is concentrated along the epithelial surfaces of the body, the gut, the respiratory tract, the skin, where the human body interacts with the environment. So that's where vitamin D is most active. In terms of background, before we did the VDAR trial, there were rodent studies that demonstrated a variety of different and human studies that demonstrated that vitamin D had important effects on the developing human lung. The rodent study showed that there were vitamin D binding sites on alveolar type 2 cells, that 125 dihydroxyvitamin D stimulates surfactant phospholipid and protein synthesis. The fetal fibroblasts produced 125 dihydroxyvitamin D, that the alveolar macrophages were able to hydroxylate 25D to 125. And in human studies, that vitamin D was required for branching morphogenesis in the human lung and for the development of alveolar macrophages in the second and third stages of fetal lung development during pregnancy. Now, how common is vitamin D insufficiency and deficiency worldwide in pregnant women? That's what this slide summarizes. You can see that most of the studies have been done: Canada, United States, Western Europe, uh, um, Southeast Asia, almost none at all in Africa or the Soviet Union. On the left-hand side of the slide, you can see that vitamin D status is listed in varying shades of red, depending on whether it's less than 12 nanograms, less than 20, or less than 30 nanograms. And it's really those latter two categories, less than 20 and less than 30, that make up the bulk of the studies. And then if we shift to the right-hand side of the slide, you can see over here that serum vitamin D levels there's a wide variety. Between 4 and 60% of women have less than 20%, 20 to 90% have less than 30%, 30 nanograms per ml, and 100% have less than 60 nanograms per ml. So we'll come back to the 60 nanograms, but the point of this slide is basically that vitamin D insufficiency and deficiency are very common in pregnant women. Third point I want to make in terms of background is just a little bit about the biochemistry of vitamin D. So, with sun exposure, uh, um, the skin converts 25 cholesterol to vitamin D3, which is hydroxylated first in the liver at the 25 position and then in the kidney at the 1 position to make the active form 125 dihydroxy vitamin D calcitriol. And that form is the form that goes intracellularly that then activates uh, uh, um, by binding to the vitamin D receptor, activates a downstream host of enzymes that are involved in both endocrine and autocrine and paracrine functions. Now, the other important point about the biochemistry here is that the 25-OHD is what we measure in the serum, both in pregnant women and in all stages of sort of clinical use of vitamin D, not the 125. And that's because the 125 has a very short half-life. So it's important to recognize that we're mostly interested in what's going on within the cell. We can't measure that. We don't measure the 125. We're measuring the 25. So we're measuring a proxy of a proxy to give us a sense of the vitamin D status of an individual. So just to summarize what was known when we started to do VDART, we had identified that the vitamin D receptor locus, the gene for the vitamin D receptor, was linked to asthma. We had done 2 studies of vitamin D intake, not levels, but vitamin D intake in the mother that were linked to asthma wheeze outcomes in children. So we found that there was about a 50% reduction in asthma wheeze in the offspring of the children if the mother was taking higher levels of vitamin D. So this was not a study of levels, it was a study of intake. Clearly, the endocrine effects, the bone-related effects of vitamin D are linked to the serum levels of 25-OHD, but these immune effects that I talked about, those are really linked to the tissue levels, which we can't measure. And the relationship between the serum levels and the tissue levels is not quantitatively determined. We don't really have a way of directly relating what's going on in the serum to what's going on in the tissues. And the final point is that there's literature about vitamin D and its effects in pregnancy, that vitamin D clearly mediates a lot of different aspects of pregnancy and postnatal immune function. One way to think about this would be to say that what vitamin D is doing is modulating how the mother and the fetus interact during pregnancy and controlling the mother's immune system and the development of the fetus's immune system so that to minimize any adverse interaction between the mother and the fetus. So the other point that's not shown on any of these slides, but it's critical, is that asthma and wheezing as an outcome is really something that happens very early in life. Most wheezing happens in the first 3 years of life, and almost all asthma is diagnosable by age 5 or 6. So we're looking at in this trial, we were looking at giving vitamin D to pregnant women to see if we could prevent asthma in their offspring. And here's the design of the trial. So we enrolled women who either had a history of asthma themselves or having children that had asthma or had asthma and allergies in their families. And we enrolled them between the 10th and the 18th week of gestation. Uh, um, so their first visit, that enrollment visit, was between 10 to 18 weeks of pregnancy. They were followed with questionnaire and blood draws. They were randomized to 2 groups, a group that got 4,000 IU of vitamin D plus a prenatal vitamin, so 4,400 IU in the treatment group, 400 IU in the placebo or control group, and then monthly visits where there was a blood draw in the mother at 32 to 38 weeks, cord blood draw at delivery, following the pregnancy and birth outcomes, questionnaires in the mother, urine calcium to creatinine ratios, and questionnaires and a blood draw in the mother at 1 year and the babies at 1 year and at 3 years. So the first result of the trial was how well did we do with the 4,400 IU dose to achieve 25 hydroxy D levels in the third trimester. So we looked at two target levels, 20 nanograms and 30 nanograms, both for the 400 IU dose and the 4,400 IU dose. And what we saw that there was a statistically significant increase in achieving either 20 nanograms per ml or 30 nanograms per ml with the higher dose. But the biggest point I want to make with this slide is that only 75% of the women achieved a level of 30 nanograms per ml at 32 to 38 weeks of pregnancy. So 25% of the mothers were deficient in terms of our target 25 OHD level that we had targeted in the trial. And then if you look at the results of the 3-year study, this is a Kaplan-Meier curve, the proportion of free of asthma or recurrent wheeze at age 3 years. The blue line represents the treatment group, the yellow line represents the control group, and there was a reduction of 20% in the treatment group relative to the control group, but this was a borderline statistical significance. It didn't reach the statistically significant level of 0.05, and most importantly, it didn't approximate the 50% reduction that we saw in the observational studies. So why were the VDART analyses not statistically significant? Well, I already told you that we didn't give enough vitamin D. Only 75% of the trial participants achieved the target serum level of 30 nanograms per ml. The second thing is that we didn't give the vitamin D early enough during pregnancy. You know, we were enrolling women 12 to 18 weeks during the pregnancy, but branching morphogenesis begins as early as 8 weeks in pregnancy. So there was a significant period of lung development that was going on prior to enrollment. And the third point, and this is a particularly critical point, there was vitamin D that was present in both the treatment and the placebo arms at the onset of the trial. And what this meant is that, and if you looked at the levels of vitamin D on average in the treatment group and the placebo group at baseline, it was about the same. It was close to it was 29 nanograms per ml or close to 30. But this misclassification led to reduced power to detect a difference between the treatment and the control group, which is something that's unique to nutrient trials and not what you would see in a drug trial. In a drug trial, you would see drug or no drug. In a dietary trial or a nutrient trial, you see more nutrient versus less nutrient. So we did a meta-analysis with the COPSAC study, and this was published in this paper in PLOS One. The top meta-analysis shows that when you combined our results in COPSAC, that now we would get statistically significant results with about a 25% reduction. This still didn't approximate the level of the reduction that we saw in the observational studies. In the lower panel, what you see is a level stratified intent to treat analysis. So we stratified the intent to treat analysis by the baseline level at the start of the trial. This is still an intent to treat. It's still the standard intent to treat analysis, but we've added this additional constraint that we considered the baseline level. And when we do that, the results are not only statistically significant, but they're almost exactly the same as the effects that we saw in the observational studies. We see now a 50% reduction that is statistically significant. The next thing we looked at, and this has been published in this paper in Biomedical Pharmacotherapy, is we looked at the asthma risk of asthma wheeze as a function of the maternal vitamin D level on the left-hand panel at 10 to 18 weeks of gestation, and in the right-hand panel at 32 to 38 weeks of gestation. And so this blue line and the light blue confidence limits that you see on the left and the right suggest that the maximum reduction, that the reduction of risk with an increase in vitamin D level is linear, uh, um, and that the maximum reduction uh, um, occurs at a serum level in the mother closer to 60 nanograms per ml rather than 20 or 30 nanograms per ml. So these figures are part of the basis for suggesting that the level in the pregnant woman should be at 60 nanograms per ml, not at 30 nanograms per ml, if you want to prevent asthma wheezing in her offspring. Final result from the trial is we looked in a subset of the subjects at the effect of the maternal 25 OHD level on the lung function of the children at age 6. The left-hand panel plots airway resistance, where a lower amount of resistance shown in blue versus the higher resistance in red, or higher lung function in the right-hand panel, which is in FEV1, forced expiratory volume in 1 second. Again, blue is better, red is worse, suggesting that those who had a mean gestational 25 OHD of 34 to 71 nanograms per ml, the dark blue, had the best lung function of the children at age 6. So improved lung function at age 6, reduced asthma wheeze at age 3 and age 6 are what we saw when we did the appropriate analysis in VDART. So vitamin D is necessary at every stage of pregnancy and beyond. Vitamin D sufficiency early in pregnancy has a greater effect on asthma outcomes than later in pregnancy. Nutrient trials are fundamentally different from standard drug trials because there's contamination in the control group. Level stratified intent to treat analysis suggests congruence between the observational and clinical trial results when initial levels of vitamin D are accounted for. And the effects of vitamin D are statistically significant at 3 to 6 years for asthma wheeze and for lung function at age 6. Now, let's try to take these trial results and put them in some sort of context. So the first thing I would say is that there are a variety of nutrients, and I've plotted vitamin D, vitamin A, omega-3 fatty acids, and vitamin C here, that have some degree of effect on airway development, lung development, immune system development, and are deficient during during pregnancy and have been looked at in controlled clinical trials. And it's really, vitamin D is the only one of these nutrients that meets all of these criteria. I think there is some suggestive evidence that that omega-3 fatty acids may interact with vitamin D, but of all of these nutrients, the results are most consistent for vitamin D in terms of its overall impact, and the data is the strongest. It's important to recognize how vitamin D is actually working here. I didn't go into the genetics and genomics of this. It would have taken me too much time. It's a whole separate talk. But the way increased vitamin D works, it decreases preeclampsia risk, it decreases preterm birth risks, and by both of the effect of both of those is to increase gestational age, increase the sphingolipid levels in the lung, which improves immune system maturity and lung maturity, and hence reduces childhood asthma. So we have a pretty good idea that the primary biochemical pathway is sphingolipids, and that the effects of vitamin D on child asthma wheeze is at least in part mediated by the improvements in preeclampsia and preterm birth, as well as directly on improving gestational age. So preventing preterm birth and preeclampsia with higher vitamin D, coordinate maternal with the fetal innate immune system, and allows the fetal adaptive immune system to develop appropriately over the first years of life. reduces the inflammation that's seen in early pregnancy with implantation, improves branching fetal morphogenesis and alveolarization of the fetal lung, preventing alveolar wall remodeling, genetically control and directly increases sphingolipid production, enhances the fetal response to viral infection in early life, decreases the allergy response, increases the infant lung function. So these are all of the different ways that vitamin D prevents asthma in utero in an early childhood. Now, what's the potential public health impact? Well, VDART suggests a 50% reduction in asthma risk at a suboptimal dose, maybe 80 to 85% reduction at an optimal dose. We can discuss what that optimal dose is when we get to the questions. The risk of childhood asthma is a continuum. As you can see from those risk curves that I showed you, it's not categorical. The higher the level of vitamin D early in pregnancy, the lower the risk. Long-term protection is linked to change from baseline level with the intervention. Prevention is directly linked to early intervention with preconception being best. And the optimum serum level is probably 60 nanograms per ml, not 30. So the magnitude of this problem, if you've got 70% of pregnant women with vitamin D levels less than 30, you have almost 100% of pregnant women who have vitamin D levels less than 60. Current recommendations for vitamin D intake during pregnancy are all inadequate. The USDA recommends 600 IU of vitamin D, but we were using 4,000 and we didn't get a high enough dose. The IO recommends a serum level of 20 nanogram per ml during pregnancy. It's totally inadequate. The Endocrine Society recommends a serum level of 30, again, with a dose up to 4,000, which is what we used, which is probably not enough. The Cochrane collaboration recommends further studies, and their meta-analyses do not account for either obesity or baseline level. And most OB programs, including the Brigham, do not recommend vitamin D supplementation during pregnancy. One of the places that does is the University of South Carolina in Charleston, where Bruce Hollis is at. So finally, these are all of the people that worked on the trial. Bruce was a consultant to this study. I love people from the Channing Division of Network Medicine who did the analyses that I presented to you. Collaboration with people at COPSAC, three clinical centers, Kaiser, Washington University in St. Louis, and BU Medical Center, my long-term colleague Gus Latunwa, and the NHLBI who funded the study. So why don't I stop there and stop sharing? And pretty good. We're almost at half an hour.
You did fantastic.
Went through a lot of material. So now we can take questions. We've got Jen's got some questions that she's going to ask me that, but then people, if they have other questions, they could put them in the chat.
Yes. And I do want to mention just a few other things before we start. We've seen evidence that if a pregnant woman enters pregnancy with a vitamin D level of at least 40 nanograms per milliliter, her risk of preeclampsia is virtually none. Does your research agree with that?
Um, I, I would say, let me just say a couple of things. I think that almost this demonstrates how difficult it is to do nutrient trials during pregnancy. Because ideally, if you were going to do a trial, you would randomize people pre-pregnancy. And so I think the idea that women going into pregnancy having a level of at least 40, even if 60 is the ideal, you're less likely to have a miscarriage. You're more likely to carry a baby to term. You're less likely to have preeclampsia, less likely to have preterm birth, and you're going to be less likely to have a child that has asthma and wheezing during their first few years of life. So I would say it would be ideal if every pregnant woman went into pregnancy with a level of 60, but 40 is pretty good. And I think that the risk of of preeclampsia is markedly diminished with a level of 40. Uh, Probably not to zero, though.
Okay. All right. And you know, again, I the importance of nutrient study design, especially in terms of vitamin D, when you're looking at studies that don't include pregnant women, it's already difficult enough to analyze it. There's just so much research that's been done incorrectly, we could say, especially ignoring the baseline levels and all of that. But then, as you mentioned, when you start looking at pregnancy and prenatal outcomes, you're right. So much happens at that very beginning part of pregnancy before a woman usually even knows that she's pregnant. And I think you and I had this conversation before to have a very well-designed randomized controlled trial that enrolled women pre-conception would cost a ridiculous amount of money and would probably never happen.
Yeah.
But speak to the safetiness of vitamin D. Have you ever seen any issues with toxicity? And have you ever, given pregnant women more than 4,400 and seen any issues with toxicity? What are your observations with that?
Yeah, so we monitored. One of the things that was required by NHLBI was to do very careful safety monitoring during VDART. We saw no adverse side effects. I think that if you've got people who have normal renal function, their kidneys are normal. Um, the chances of any adverse side effects during pregnancy with doses of 6,000 or 8,000 or even 10,000 IU a day are really none. I personally have not done any studies with doses higher than 4,400 IU, but there are at least two or three studies reported in the literature in pregnant women that have used 6,000 and 8,000 and no adverse side effects. Again, based on our trial, to get to 60 nanograms per ml in everybody would require at least 6,000, if not 8,000 IU to get everybody up to 60 nanograms per ml, which would be what I would view as minimal risk. So I think for young, healthy, pregnant women, having that, I have not seen any side effects, but I haven't done studies with those higher doses.
Okay,
Although there
thank you.
are a few reported in the literature.
Thank you. Okay. Um, and you and I had a conversation before we started about the importance of dosing by weight or considering obesity as you're deciding how much to give. You've seen results from trials such as your own trial and the Vital trial that have been reanalyzed based on BMI, and you see the effect of vitamin D on intake on those health outcomes, but only among those with normal BMI. Can you kind of go over the importance of that, what that
Yeah,
indicates
so
in terms
so
of?
I think this was the hottest topic at the vitamin D workshop in Montreal th this past year, 2025. Uh, um, so in the Vital trial, which was looking at adults with heart disease and cancer outcomes, what they found was that when they stratified by BMI and looked at normal weight individuals, what they saw was a protective effect from vitamin D that they didn't see before. And it was and they saw no effect in the obese people. When we reanalyzed the results of VDART by the baseline pre-pregnancy BMI, we found that there was no effect of the vitamin D on preeclampsia and preterm birth in those mothers that were obese entering VDART. Now, vitamin D is a fat-soluble vitamin. So if you, for whatever level of vitamin D you're taking, there's going to be sequestration of vitamin D in the fat. And how this actually works Again, we don't fully understand all of the biochemistry here, but for any given dose of vitamin D, a chunk of that vitamin D that's ingested is going to go into the fat. And the fatter you are, the more that's going to happen. So that means that less vitamin D is available for use by the immune system and use at these mucosal surfaces and so on. So what we've shown in VDART is that if you stratify by the level of obesity, that you can overcome the effect of the obesity by giving a higher dose. So if you give a higher dose in the obese, you can then prevent some of that preeclampsia, preterm birth, asthma, wheeze. There may be an additional component of the obesity because obesity is an inflammatory state where it's influencing the biochemistry of what's actually happening with vitamin D metabolism. We don't know the answer to that. But I think the basic point here is that now what we're saying, and I think that this is going to be the consensus opinion, is that you almost have to have two sort of separate dosing standards, a set of standards for people that have normal weight and a set of dosing standards for people that are obese. And so while 2,000 to 4,000 IU may be fine to prevent cancer and heart disease in the non-obese, you might need 4 to 6,000 IU of vitamin D in the obese to get the same reduction in cancer and heart disease risk. Those studies haven't been done, but it would be my intuition from what I know about how vitamin D is a fat-soluble vitamin, that there's this additional, and I think I mentioned this to you before we got on the webinar, is that in some ways you can conceive of pregnancy as almost an obesity-like state, right? Because what you've got is a placenta and a fetus that need a requisite amount of vitamin D independent of the mother, so that the reason that you need this higher dose, 6 to 8,000 or 6 to 10,000 in the pregnant woman is that you've got to have adequate amount available for the fetus. So if you add obesity in the mother on top of that, you're going to need even more.
Mhm.
I, I think that again, the Cochrane collaboration, which does all these meta-analyses and is sort of deemed the arbiter of what's real in the clinical trial space. They don't consider obesity and they don't consider baseline levels. So in my view, most of those meta-analyses that they do don't really get at the magnitude of the problem in terms of what's actually going on.
Right, right. And I think Dr. Hollick, in his vitamin D study hour that we did last, mentioned that obese people likely need at least 2 to 3 times as much vitamin D
Right.
as a normal BMI individual. And then kind of piggybacking on what you were saying about 6,000, closer to 6,000 possibly being the correct dose for a normal weight pregnant women. Um, I did have a question about breastfeeding, and I also want to add a note before I ask that question because I know that Doctors Hollis and Wagner have shown in their trials on breastfeeding mother and infant pairs showing that a breastfeeding woman needs at least 6,400 IU of vitamin D a day to provide her baby with that 400 IU of vitamin D in her breast milk per day. And so it would make sense that perhaps that 6,400 is closer to what a pregnant woman might need as well. But one of the questions that we received was if a mother who has asthma but controls it through breath work did not supplement with vitamin D during pregnancy, but supplements while breastfeeding, To what extent would her baby benefit in the same way as if supplemented during pregnancy?
Yeah, okay, this is a great question. I think, and this cuts to the heart of this of the fetal origins of chronic disease hypothesis. So the fetal origins of chronic disease suggests that fetal programming of the fetus during pregnancy is critical to their postnatal disease risk. And so let me give you some concrete examples. Pregnant women that have preeclampsia are predisposed to have babies that are more likely to have high blood pressure. Okay? That has to do, at least in part, with programming the fetal vasculature to respond in a certain way. So the whole hypothesis behind VDART is that we would use the vitamin D to help the development of the fetal lung during pregnancy. So the asthmatic pregnant woman who only gives vitamin D postnatally is abrogating or eliminating all of those effects of the vitamin D during pregnancy. So they're going to have a baby that's got an abnormally developed fetal lung that's going to be predisposed to asthma, even if they give the baby adequate vitamin D postnatally. VDART didn't study this. We did not do a good job of studying postnatal vitamin D. We do have information on breastfeeding. We do have information on whether the mother took vitamin D. We do have information on the mother's asthma status during pregnancy, which I can talk a little bit about. Uh, 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 but to assume, which the questioner's question assumes, that pregnancy and postnatal vitamin D supplements are equal is a fallacy. It's not, the two stages of life, the actual pregnancy itself is extremely important because all of the baby's own biochemistry is being set during that pregnancy. And then the baby comes out into the environment and has additional setting of that biochemistry, but it's on the background of whatever happened during the pregnancy. So I would say that breastfeeding pregnant women require at least 6,000 IU of vitamin D. I would say that if the mother was getting 6,000 during pregnancy, that maybe she should be taking 8,000 postnatally if she's breastfeeding. It's not clear to me that 400 IU is adequate for a neonate in the first year of life. I mean, I would probably lean more toward a dose in the first year of life of 1,000, and then when the baby gets to be two, give it 2,000 and continue that on as they get older. And there's no question that during that first year of life, what the baby is doing is switching from its own innate immune system to developing its adaptive immune system. And vitamin D is enhancing that immune system transition. So this is a critical stage in the immune system development of the child. But I think it would be wrong to assume that these two stages of development are equal.
Right, right. No,
So
definitely
the other
still
thing,
beneficial to supplement during breastfeeding,
yeah,
as soon as possible. But you're right, the programming, pre-programming happens during pregnancy for the
right.
most part. Yeah,
The other point that this question brings up is the control of the mother's asthma. We found very definitely in VDART that the better the mother's asthma was controlled during pregnancy, the better the outcome of the baby. So asthma control during pregnancy does influence the fetal development.
Okay, thank you. And there was a question submitted that's along the same lines. Is there any research or information on whether vitamin D helps um, parents with asthma or patients with asthma? It might be typed in incorrectly, but what about later on in life? What research have you seen in terms of vitamin D and asthma?
Yeah, so that's a that's a great question. That's a secondary prevention question. How much can you improve the asthma in either children or adults for people that already have asthma? And I think the answer to that is that most savvy asthma doctors do prescribe vitamin D to their asthma patients. And the reason for that is that there's immune uh, benefit to the vitamin D because what happens with asthma is that these patients, for the most part, take inhaled corticosteroid. And that inhaled corticosteroid is less effective. You're more likely to have steroid resistance if the vitamin D level in the asthmatic patient is low. So by giving vitamin D, you enhance the ability of the inhaled steroid to actually get into the airway epithelial cells and decrease inflammation. So I would say that the secondary prevention trials have been a mixed bag for a lot of the reasons why nutrient trials have been a mixed bag for other reasons. They have used a too short a run-in period, not a high enough dose, haven't adjusted for initial level, all of those problems. So I would say that the clinical trials data supporting my opinion is maybe less good than what I would actually do as an asthma specialist taking care of a patient.
Mhm, mhm. And you and I did start also talking about the certain tissues that had a higher need or affinity for vitamin D. And you mentioned it briefly in the beginning, but according to your other research paper, like for example, not just asthma, but let's say somebody has colon cancer, and we know that research has shown a very strong correlation between colon cancer and vitamin D levels. Now, could it be that there's certain tissues that require more vitamin D, maybe because they express the vitamin D receptor more, and in situations that are affecting those specific tissues or organs, would that be a higher indication that vitamin D might be of higher priority for them?
Yeah, so I think that when you and I were going over the questions, the person that put in this question talked about 50, vitamin D being associated with protection for 50 cancers and what was the relationship of tissue specificity of vitamin D in these cancers and so on and so forth. So, I, first of all, let me say I'm a genomics expert, I'm an asthma expert, I'm a vitamin D expert, but I'm not a cancer expert. So I have not personally reviewed all of the literature about vitamin D and the 50 cancers. So I can't tell you about that. It stands to reason to me that uh, 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 um, cells or tissues that express the vitamin D receptor might be that those cancers might be more or less protective. Vitamin D have a more protective effect. But as I said to you, I don't know of any studies. So one could use a technique called ChIP-seq to tag all of the vitamin D receptor binding sites in the human genome. And this study has been done, by the way. So all that the ChIP-seq for vitamin D receptors has been vitamin D receptor binding has been done. But you could go look at those tissues that are encoded by those genes and then determine how many of those tissues were indeed vitamin D responsive tissues. Now, pretty clear that uh, 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 colon cells, absolutely, that they're epithelial cells, they're exposed to the environment, they are likely to have a high propensity of having vitamin D receptor binding sites. But I would also say that there are some tissues, like lung tissue, where the determining effect of the vitamin D was on sphingolipid biochemistry, not vitamin D receptor binding, where it was different biochemistry. So it isn't true that that would be the only way that vitamin D could be influencing these cancers.
And didn't you start out your presentation saying that one of the observations that you had made before you started the VDART trial was that there was a relationship between the VDR polymorphism and asthma?
Yes.
Okay.
Yeah. Yeah. So in the case of so that is an interesting finding, but it was also a finding that shows how complicated this is. So the number one genetic locus for asthma, particularly childhood asthma, is the locus 17q12.21. That locus has a VDR binding site in two genes, ZBP and one other gene. I'm blocking the name of it. But those VDR binding sites were not in the vitamin D receptor. They were in these other two genes, and these other two genes were critical for sphingolipid production.
Mhm.
So I'm just saying that there's a lot of complicated biochemistry and a lot of different genes that are potentially involved. And VDR is only one of those and only one of the things that's influenced by vitamin D.
hmm Right. And so, a question from a participant to piggyback on that. How much do you think of that 25% group of women who did not achieve the level of vitamin D status was due to genetics?
Uh, yeah, you and I had this conversation before, and uh, um, I'm a much bigger believer that genetics plays less of a role than dose. So I think that the women, first of all, remember that the target level was 30. And I've already said that the target level of 30 was inadequate. It should have been 60. So the target level in VDART was pretty low. 25% of the women didn't get there. But I think that the majority of those women didn't get there because they started too low, or they were obese, um, or they may not have been taking their medication. Now, compliance was a whole separate thing, but I would put more weight on what their starting level was and whether they were obese than I would on their genetics. I think people get very fascinated by the genetics. As somebody who is a geneticist and has done a lot of genetics, I think it's very useful for looking at the ultimate biology and biochemistry of what's going on. But I think most of what determines people's levels is their behavior. How overweight are they? How much time do they spend outside? How much vitamin D do they take? Do they exercise? Those things count 10 times more than the genetics. in my view.
And also affect the vitamin D level itself. And I think we're going to discuss that topic with Dr. Frame April 15th, I believe. And then in conversation with Dr. Coimbra in Brazil, who, he focuses on autoimmune diseases, especially multiple sclerosis. And he does a different, he uses therapeutic doses of vitamin D to treat a condition. But even, in his patients who can't learn to manage their stress, he can't always overcome that with the vitamin D, or when patients do learn how to manage their stress, he can actually lower their level of vitamin D. But again, he doses based on the PTH level, and so that's a whole other this whole idea of vitamin D resistance and vitamin D dose response. There are so many different factors that play into that, but then also diet, exercise, sunshine. Those are all key lifestyle things that we really have to focus on as well. I have two questions that I want to kind of follow up on this with. Kind of going back to your recommended levels and dosing. I had somebody ask, what are the safest, highest doses of vitamin D to give during pregnancy if a patient is severely deficient, as in 8 nanograms per milliliter? What dose can be given as loading doses followed by a maintenance dose?
Yeah, um, again, I don't have a lot of experience of that. We did have some women in the trial that were at 8, and they came up very rapidly with a 4,400 IU dose. Uh, uh, um, I'm not sure what I would do. Uh, I think it would depend on exactly what stage of pregnancy they were at. As to whether I would give a loading dose. I don't really have a good recommendation for that. But I mean, if somebody was below 10, and it was very early in the pregnancy, I mean, 5 weeks or something like that. I mean, giving a a daily dose of 10,000 and a loading dose of 50,000 would be perfectly appropriate.
Mhm.
But I think it's very unusual to see somebody at that stage of pregnancy, right? I mean, most of the time women don't come to their obstetrician until after the 8th week. So,
Right.
I might still give I mean, giving a 50,000 IU loading dose and then a dose of 8 or 10,000 IU daily, it's it'd bring you up very fast, and would have minimal, if any, side effects.
Mhm. I have a few more very interesting questions, so I'm going to keep it going past the hour. I hope that's okay with you. Uh,
Yeah, yeah.
Given the marked physiologic rise in 125 OHD during pregnancy without hypercalcemia, should clinicians be less concerned about higher vitamin D intakes in pregnancy when calcium and renal function are normal?
Yeah, I mean, I think the answer to that is obviously yes. I mean, I think that I think calcium has almost nothing to do with the rise in the 125 dihydroxy vitamin D during pregnancy. That is all about providing adequate vitamin D to the placenta and the fetus.
And that's the only time in the life cycle that happens, right?
That's correct.
Yeah, yeah. Okay. And then one other question on the dosing questions. So, she asked if you would normally start with 4,000 IU and then correct the dose by measuring the blood level. But the other part of her question, which I think is a really great question, is do you wait 2 to 3 months uh, to remeasure? As you know, that's what we suggest. You give the vitamin D level time to adjust to the dose. Or would you want to remeasure sooner to make sure that she's responding to that dose?
Well, I mean, I think we have to distinguish here between she's talking about a normal adult, not a pregnant woman.
No, I think the pregnant women, because we were discussing pregnancy.
Well, you have so little time during pregnancy I mean, pregnancy happens. It may seem like an eternity to a pregnant woman, but it's really it's over before it starts. So I think based on what I know, what I know right now, in terms, I would give obese pregnant women 8 to 10,000 IU. I would give a pregnant woman 6,000 IU, and I would I wouldn't worry too much about remeasuring the dose. By the time we did the second dose, it was the 32nd to the 38th week. The pregnancy was virtually over.
Mhm.
So I would count on the fact that I have a pretty good idea based on the trial what sort of dosing I need to give to somebody who's obese and somebody who's non-obese and go with that.
And what percent of women were obese in the VDART trial?
Um, I think about half of them were
Okay.
overweight or obese. Yeah.
Okay. Yeah, so I was very honored to be a part of the Medical University of South Carolina prenatal project that Grassroots Health did, along with Bruce Hollis and Carol Wagner
Yep.
and several other key figures there. And I know that what we did, we measured at the very first prenatal appointment, measured again, I think it was around 24 to 26 weeks, and then again around 34 to 36 weeks to ensure
Right.
that we were dosing correctly. And we were dosing using our calculator that goes by weight.
Right.
And we continued to remeasure the vitamin D level until that woman reached a level of at least 40.
Yeah.
So that is one way
Well,
to do it.
that's a perfectly reasonable approach to this.
Hmm.
I don't think there is sort of one way to do this. I mean, you and I did have the discussion about there's a lot of controversy now for non-pregnant people about when vitamin D levels should be measured or shouldn't be measured. And there was just an article in the New England Journal of Medicine suggesting that primary care physicians should not measure vitamin D levels. My own personal feeling about this is that I think that given that the health consequences of low vitamin D are so significant, I would prefer to know that my serum level is normal, and I would prefer my primary care physician to measure it
Hmm.
rather than not measure it if there was any question about whether I was sufficient or not. And
Right.
I can't tell you the number of people in my own laboratory who didn't know they were vitamin D deficient, and then they had their vitamin D measured and they were. So it's a much bigger problem than people think, particularly if you think that given this obesity thing and the fact that the level that's protective is probably for cancer and heart disease and whatnot is likely higher than it is anticipated. That people keep saying, "Oh, 30 is the level you should have." No, I think in pregnancy it should be at least 60, and I'm not sure that for non-pregnant conditions it shouldn't be 60.
Right, right. And I think you pretty much answered this question with that. I'll reread it and then you can add to it if you like. What's your opinion of the Endocrine Society's decision to recommend that clinicians not test patients for vitamin D and not recommend supplements? What's the policy among the American College of Obstetricians and Gynecologists about supplementation and testing for vitamin D status?
Yeah, I think that both the endocrine societies recommend. The American College of Obstetrics and Gynecology has no position on this. They don't have a position, and I think that the endocrine society is wrong. I mean, they're basically wrong about this.
Right.
I think that part of the problem. I mean, if you talk to any of the sort of older school vitamin D experts, Bruce Hollis, Mike Hollick, and you ask them, what's your vitamin D level? They'll all say 60 nanograms per ml. That's what they'll say. So I think that tells me that they know something that the rest of us ought to be listening to.
Mhm.
Uh, uh, um, so I think that we've still got a long way to go before. I think that again, part of the problem here is what the geneticists call pleiotropy. You've got a large portion of the scientific community that sort of looks at vitamin D only in the context of calcium and bone health. And then there's a smaller, more advanced group that sort of looks at this in the context of immune health, cancer, autoimmunity, and so on and so forth. And if you look at that group, that's where this higher level, the push for the higher levels is coming from.
Right, right. Yeah, there's certainly people who still focus so much on bone health, and that's all that matters for vitamin D in the guidelines. And we've had Dr. Bill Grant and Dr. Michael Hollick and Bruce Hollis and several other people come out and speak to that topic. And it relates to this very last question that I have for you from one of our attendees. In your opinion, what differences in further research need to be looked at or threshold for total evidence needs to be reached in order to support a revision in the public recommendations for vitamin D supplementation during pregnancy?
Yeah, great question. Yeah, yeah, uh, um, yeah, they're going to have a consensus conference. That's sort of planned by the NIH for this next year. Uh, um, it'll be interesting to see what comes out of that. Um, I'm not sure that in terms of pregnancy recommendations, more clinical trials in the context of the United States are even ethically possible, given the limitations on the clinical trial methodology. I think that more research clearly needs to be done on this obesity thing because if it turns out you need one sort of dosing schedule for the non-obese and another dosing schedule for the obese, we need to know that. So I think that's probably the most important, and that involves some reanalysis of the existing trial data. Uh, um, but I think we're a ways away from a consensus here, and it's not entirely clear to me how we're going to get to one. We're clearly going to need more research, but exactly what sort of research we need, it's hard to know because I think there are a lot of people that don't. I was impressed by some of the naivete amongst a lot of the participants at the vitamin D workshop in Montreal, that people who were supposed experts who really didn't understand this. So
Mhm. Yeah, yeah.
we'll have to see what it's clearly complicated.
Yeah. And yet it's been um, discussed far back. Dr. Robert Haney, he published his paper on guidelines for proper nutrient studies, including vitamin D. I think it was in 2014. We've been talking about this for years.
Oh
I
yeah.
had you on for a presentation where we really discussed this topic in a lot of detail. And I
Yep.
think that was sometime last year, of course, but it's on our YouTube. So I would highly suggest that anybody who's interested in that go to the Grassroots Health Vitamin D Action YouTube channel and find our last presentation with Dr. Weiss. But yeah, it's there's slow movement. You know, we went to DC in September and had our, research and our maternal vitamin D initiative and had a lot of great conversations. But as somebody within all of that quoted, everything at that level moves at glacial speed. So
I
it
think
really
what
is up to us to.
I think one of the things that's most distressing to me is that I don't think the clinical trials community has understands what Bob Haney was talking about, and to insist on standard clinical trials as being the end all be all, particularly when you're talking about a nutrient and its actions during pregnancy. I think you're not going to be able to achieve that using sort of the standard clinical trial approach.
Right. No, not at all. And again, we've got so many great resources. I did recently post one of Dr. Haney's last presentations that he did with us on nutrient trial design. That's also on our YouTube. I've written several blogs, have a great uh, downloadable infographic that reviews each of those criteria for how to review and look at vitamin D research and their conclusions. Really important to know. So with that, I'm gonna start our closing. Do you have any other key points? Anything else you'd like to say?
No, I think the questions were great and it's a very good discussion.
Thank you. Yeah, and I apologize, I did not get to all of the pre-submitted questions. We went through all of the questions submitted today. If anybody has any additional questions, something that they're dying to get answered, please email me, Jen at Grassroots Health, and I will forward them on to Dr. Weiss. In the meantime, thank you so much for joining us, Dr. Weiss. It was a pleasure.
Yeah,
Uh,
thank you, Jen.
you're welcome. Well, enjoy the rest of your day. Thank you.
You too. Bye.
Bye.